Okay, everyone, we're going to do a quick little class here on STAR Triage. It's kind of a foundation of mass casualty care. It's a peer-reviewed tool. It's been out there for many years. I think a lot of people are used to it. A lot of people are used to the system. And we just kind of want to do a little quick refresher on it for everyone. So what are we going to learn today? We're going to really learn what is STAR Triage, how to use it, what the process is for STAR Triage, how to prioritize those patients, really how to do the rapid patient assessment and some of the interventions according to the triage priorities, and then use critical thinking and decision-making skills to adapt triage strategies in these complex scenarios. Really, when we look at STAR Triage, it's been around for many, many years. It is a clinical assessment tool, but really it's a quick clinical assessment tool that's used to make resource decisions, right? So we're basically trying to figure out quickly in a minute or less, okay, who's passed already, who's really sick, who's kind of sick, and who needs immediate care, and who can wait a little bit and be transported later, right? So we want to try to figure out who needs the most care right now that we are able to offer given the resources that we currently have, and who doesn't need as much. So the STAR Triage is basically a rapid system to triage patients to figure out who needs to be transported first, who needs care first, and then who's already passed. So there's 4 basic levels right here we can see. So immediate is our red patients. Those are our really sick patients that we have the resource to be able to take care of. Yellow is our delayed patients. They may have some injuries, they may have some issues going on, but really, the reds are going to take priority. And then the greens are our minors. Those are walking wounded. They may have an injury of some form, but they're able to get up and ambulate. And then those dead or deceased patients, those are the black patients. And those are the patients that basically we don't have enough resource to take care of them right now. We don't do, in these mass casualty situations, we don't do CPR necessarily if we don't have the resources to do it. And so these are the patients that have already passed. How does it work? Well, basically we use the 32 can-do mnemonic or the RPM mnemonic. So what we're looking at when we assess the patient is we look at respirations. Are the respirations greater than 30? We check a quick pulse or a cap refill. So I like cap refill. We go with, is the cap refill greater than 2 seconds, right? It works a little bit quicker if you can just press a finger, push a forehead, whatever it may be, to be able to see what that cap refill time is. And then mentation. Are they able to simple follow commands, right? What's some of those simple commands that we can use? Like when we get on scene, the first thing we want to do is we want to say, hey, everybody that can walk, I want you to stand up and I want you to walk over there, right? And when we're doing this for scene management purposes, we want to have them stand up and we want to have them walk. And we mean walk. We want them to walk a ways away from the scene so that it's safer for us while we're taking care of everybody else, but also, they can cause distractions and get involved in stuff that they don't need to. Also, there's other concerns about traffic or if they have family members and friends that are still being worked on, things like that. And really, we also want to be aware that this and all these criteria, they're dynamic criteria, right? So once we say, hey, these are the green people, we're going to send them over there. Those are greens. Do we need to go back through and re-triage this population and all of our patients that we've got here? Yeah, of course we do. So definitely, can a green patient become a yellow patient, become a red patient, become a black patient? For sure they can if we have a lot of patients on scene and we need to be taking care of them. And we'll talk more as we get through these different levels. So delayed are yellow. So these are severely injured patients who needs evaluation and treatment, but may not require immediate transport. And a lot of times these yellow patients are those that can't walk, right? So they may have lower leg injuries. They may have, something going on to where they just can't walk. And, they need a little bit more resource, right? If they can't walk, what do they need? Well, they need a stretcher, right? So they need that extra resource of having the stretcher be able to be transported to the hospital. But they do have a respiratory drive. And for the most part, their RPM, that 32 can do, is going to be within normal limits or close to normal limits. So then our red patients, these are immediate patients. These are the people that need the most resources that we're able to offer to them. They are the patients that are critically injured. and they must be transported as soon as resources allow. So they're the ones that are going to have respirations greater than 30 times a minute. They may have low perfusion, no radial pulse, or capillary refill time of greater than 2 seconds, and they're unable to follow simple commands. Now, these patients are going to be some of our most complex patients, and even inside these patients, we may have to go through and we may need to triage based on our transport capabilities of which red patient needs to go first and which red patient we can work on a little bit on the scene, or may need to wait for the next available resource, right? So when we're doing that, we're looking at, our air resources available to take them, in our local area, in the Madrigal area, are they able to take them to one of the level 2 or level 1 trauma centers, especially with burns, things like that are going to complicate this. And do we need if we got we got a bunch of patients, but we've got a really bad soft tissue injury or a really bad burn patient, we may wait a little bit on that patient to get them on the helicopter that's inbound and get them to, one of the burn centers, and have a red patient that's still critical, may still have some injuries, and we send them to the local ER. So, and then our deceased or our black patients, those are any patients that do not have a respiratory effort, and we do attempt to open the airway in the start triage process. And basically those patients that are going to die before treatment is available. So, you still may have respiratory drive, but we may have exposed brain matter. We may have some injuries inconsistent with life. And you'll kind of see those things as you go away. Now, the question always comes up is, once you have one of these patients in the deceased category, can they move to a different category? Well, of course they can, right? If you get on scene and the first person you see is the most sick person or the most injured person, right? And you're like, oh, there's no way we're going to be able to take care of this person. But yet you go through and triage and you have all greens otherwise. Well, hey, now you might have enough resource to go back or to continue the treatment that you started with this individual or with this patient, and then be able to work them and get them the transport resource so that you can get them to where they need and may be able to save the person or provide some good care. So those are the 4 different criteria really in the start triage process, based on those 4 colors. Pretty simple explanation that we went through. I know there's some more intricacies that we can go back and forth on, but in this color system, that's what we're going to cover. So when it comes to triage swag, I always like to talk about this, right? Triage tags, they're required by the state of Idaho to be on every ambulance. You're required to have some form of NCI or triage kit available. So you can see the triage tags here on the left-hand side. Pretty cool. They also allow for, they have the RPM mnemonic on there, so you can answer those questions, help you make that decision on what your color is going to be. They also have a place where you can put vital signs, right? If you have a lot of patients on scene, you might, during your transport, you might, put your notes on there so that when they get to the receiving facility, they've got a set of vitals, couple set of vitals. Maybe you give some medications to the person. You write down those major injuries, right? You can put the notes on the back of the card with the allergies, the prescriptions, address and stuff, you can find it. And also you can rip off those are usually rip off the colors on the bottom so they can see. Now, I think the most important top part really for the use of the triage tags is if you see this number up here on the top in the yellow, and it's also on all the colors on the front side of the tag, that's actually a tracking number, right? So when we go out and we go through and maybe we do our first set of triage, and we throw that triage tag on that person, and we rip the collar off, at that point, we're going to go through and we're going to rip one of those numbers off so that we have it documented that this is the number that we've already gone through and triaged that person. And that way everybody else that comes through can see that they've already been triaged once. Now we can, when we go through a second time or when we start transport, and we're going to remove that second tag off the top, right? All the same numbers, all the same tracking numbers. So we know that that patient's now been transported. And then we can start keeping track of this, right? So we have a tracking device that's quicker than trying to use name and date of birth, especially if we're in a large mass casualty incident. So we can get them over to the hospital, get them to the driven trauma centers, and start to really build the information so that we can do reunification later, so that we have a tracking on how many patients are on scene, how many patients are transported. There's, if you have airplane or school bus crashes, you might have manifest that you're going to match them up against, really, so that we're not missing anybody. But always a great tool to be used. I don't think it's used enough. And like I said earlier, it's got a place for contamination. So if there's decon because of a hazmat situation, then that decon is up there too. So you can talk about that. These are the two different types of triage bags that are out there. I mean, there's dozens of different types of triage bags that are out there, but these are the two that I think are probably most well used. So you can see the one there on the left actually has an OPA, so if you do open up an airway, you can throw an OPA in there as well. It comes with some pins, markers, might have those big immediate flags so you can really see who the red patients are. Nice little belt, you put it on. Everybody loves a good fanny pack, pair of shears, walk around. The other one is this one on the right. I actually really like those ones too. Same process. You put the triage tags in there, throw some gloves in there. Might throw a pair of shears, a marker, pin light, whatever you might need. But I really like the flagging tape idea. First thing is when you're creating your green, yellow, and red zones that you're going to move those patients to for secondary triage before transport, you can just grab a piece of that flagging, tie it around a street pole, tie it around something so people know, hey, go to that green. If you've got a green tag, go to that green flag. And as you're going through patients too, it's pretty easy to just take that green flagging, wrap it around a wrist or something, maybe make a quick note, and then the next person that comes through, they can see that initial triage tag. Some agencies like it because it can be a little bit cheaper, a little bit quicker than using the triage tags. I think it works well in any situation. Big fan of either one, really. Don't have a heavy preference. So to recap, let's talk about our mnemonic, right? 32 can do is what we're looking for. RPM, respirations, pulse, and mentation. So the first one, are the respirations greater than or less than 30? It's going to move us through the algorithm. Is the capillary refill greater than or less than 2 seconds? If it's greater than 2 seconds, we're going to go to a higher level of triage, so it's going to need more resource. And then can that patient follow simple tests? Can they tell me where they are? Can they move? Can they stand up and go walk? So pretty basic. I think a lot of us learned this in EMT and paramedic school. A great foundational education. So let's go ahead and test ourselves. So I want you to get out a piece of paper. I want you to write down some notes, and I want you to take and figure out what each one of these patients is in your mind. So patient 1, we have a female in her 50s. She's bleeding from her nose, ears, and mouth. She's trying to sit up a camp. Respirations are 20, pulse is present, cap refills 1 second, and she's not responding to your commands. What are we going to think on this person? What do you think? So a lot of times, this person, I'll probably get, when I teach this course, a lot of people are going to say a yellow. Totally appropriate, right? A yellow is probably a good idea. She does have a pulse. Pulse is present. Cap refills less than 1 second. Her respirations are in normal limits, but she's not really responding to commands. You could also put her as a red, right? She's trying to sit out the can, not responding to commands. You can maybe telling us that there's a brain issue going on here, but I think probably yellow. Patient number 2, male in his 30s, complains in pain in his lower leg. There's obviously fractured. Respirations are 24. Pulse is strong. Cap is refilled. Cap refills 1 second. No excessive bleeding. What are we thinking here? Yeah, he's a yellow, right? He doesn't have a whole lot of hemodynamic instability that we can see at this moment, but that obviously fractured leg is going to cause us some resource, which means we're going to have to splint it, and we're going to have to use a stretcher to move him, right? So he's not able to get up and walk. So he's going to be in our yellow category. Our number 3 patient, our third patient states he can't move, feel his legs, respirations are 26, pulse is 110, radial, he's awake and oriented. What are we thinking on this cat? Well, he can't move or feel his legs, right? So he's not going to be a green. He's unable to ambulate. We're going to call him a yellow. We're going to put him in the leg category. He had some issue there, narrow issue possibly, or something else going on. And he's going to need to have a stretcher. Right now, at this moment, he's going to need to have a stretcher to be able to move him. So, patient number 4, male, follows your commands to walk to the treatment area. He has a large thigh laceration. The bleeding is controlled, and he has a radial pulse. What are we thinking? He's agreeing, right? He's able to walk to the treatment area. He needs some issues. He needs to go to the hospital, right? Got to get that bile figured out. There might be something else going on. We might, bleeding controlled right now. We want to continue to monitor him and make sure the bleeding continues to be controlled. But I think for the most part, he's agreeing. Patient number 5. Oh no, it's a pediatric. What are we going to do? It's a girl. She's 7. She walks to the treatment area. She follows commands and has a radial pulse. She does signs respiratory distress and has no bleeding. What are we thinking? Green, right? She's able to walk to the treatment area. And there are other pediatric-based programs or pediatric-based triage processes, specifically the Jumpstart triage. In those triage, Jumpstart is basically just a start triage, but instead of just opening the airway, you're actually going to give a couple breaths to the person. So you're going to walk around with a BVM, give them about 5-6 breaths. See if that then causes them to have spontaneous breathing, and then you move down your algorithm. So this is the basic algorithm for start triage. Pretty basic way to explain it. Just like we talked, when you get on scene, you're going to say, hey, everybody, if you're able to walk, I want you to get up, stand up, go over there to where my green flagging, or you see that guy over there waving his arms. I want you to walk over there. Those people that don't get up and walk over, you're going to start with the person that's closest to you, and you're going to start working through them. When you walk up to the person, are they spontaneously breathing? If it's no, we're going to go ahead and position the airway. If they start breathing after opening up the airway, then we put them in the red category, the immediate category. If they don't, they're still apneic, then we put them in that expectant or deceased. If they are breathing, then we're going to check their respiratory rate. If it's greater than 30, then we put them in the immediate category. If it's less than 30, then we're going to move on to checking perfusion status. When it gets to perfusion status, we're going to check a radial pulse or a cap refill. If the cap refill is greater than 2 seconds, we put them in red. If it's less than 2 seconds, we're going to move them down the process. We're going to go to the final step. We're going to check their mental status. Do they obey commands? If they obey commands, we're going to put them in the yellow category. And if they don't obey commands, we're going to put them in that immediate category. So really, to recap, it's a resource allocation tool. It's a clinical assessment that's dictating your resource allocation tool. Normally when I teach this in person, I do it really hands-on, where I have you now figure out from those 5 patients which ones you're going to send first and which ambulance or helicopter. I basically say you got 2 ambulances and 1 helicopter for 5 patients. When we look at that, so we use this tool to allocate how much resource every patient needs and who needs first transport, second transport, third transport, whatever it may be. But I really want you to remember one key note from this is when we're trying to figure out or make our transport decision on these patients, when we're moving patients in an ambulance, do we want to put 2 reds together? Absolutely not, right? We don't want to put 2 reds together. We're going to be overwhelming that one unit. So if we put a more severely injured, so if we put a green and a red together, maybe a red and a yellow together, because you're going to have to spend more time on that red patient. Especially in our rural setting, we may only have 1, 2, 3 ambulances in some of these cases. So we don't have a plethora of resource out there, so we got to make those decisions. Don't overwhelm that one crew with a couple critical patients, right? Give them a critical patient, give them a less critical patient. If you can, spread out the wealth as much as possible. And I think by following these triage criteria and following the system, learning more about mass casualty care, I think we really can make our communities safer and provide better care to our patients. As I said earlier in the presentation, obviously this is a well-researched triage criteria system that's been around for 20, 30 years. This is some of the supporting research that's come out in the last couple of years, the last 10, 20 years. That's how you know you're getting old, right? When the research is getting old. So if you have any questions about this, this is my contact information. Please feel free to send me an email, give me a phone call, tell me I was way off base, tell me this will never work, tell me, hey, it's great, thank you, I really appreciate those ones. And stay tuned for more in the future, and thank you for bearing with us today, and I hope you have a great day and stay safe out there.